Hey guys, welcome back to my channel, or welcome if you're new here. Today's topic is going to be a nutrition topic, and we are going to talk about parenteral nutrition. So parenteral nutrition is prescribed when a client's GI tract is not functioning, or the client cannot consume enough nutrients orally, or they can't tolerate enteral feedings. So therefore we need parenteral nutrition. Be sure to stick around until the end of this video because we are going to do 5 practice questions. After we've reviewed parenteral nutrition, we will practice 5 questions in which you can check your understanding of this content. So be sure to hang around until the end. Okay, let's look at a breakdown between total parenteral nutrition and peripheral parenteral nutrition. So big highlight at the top. So I just want to call out this because it is super important. You can never administer medications through a parenteral nutrition IV or a port that is connected to your parenteral nutrition. So really key point. Okay, let's do the breakdown. So total parenteral nutrition is nutritionally complete and peripheral parenteral nutrition is nutritionally incomplete. So when we think about TPN, this is going to be for patients who have very high caloric needs, such as your burn patients, a trauma patient, a patient who has a very critical illness, maybe is on the ventilator, has a cancer diagnosis, or a bowel disorder and is hospitalized. TPN is for long-term therapy, and the solution is going to contain, and this is really important, more than 10% dextrose, and that's going to make it a hypertonic solution. Now, when we think about peripheral parenteral nutrition, or PPN, remember this is nutritionally incomplete. It should be administered for no more than 14 days, and it is for short-term therapy only. And key point, the solution is going to contain no more than 10% dextrose, so 10% or less, and 5% amino acids, and this is going to make it an isotonic solution. Now, when we think about TPN, only administered through a central line. So any type of a central line, and we see a lot of course, peripherally inserted central lines, so PICC lines. With your PPN, however, it can be inserted into a peripheral line. Common uses, of course, for TPN, we've already talked about cancers, bowel disorders, trauma, burns, in which the patient really does need almost all of their nutrition or all of their nutrition administered parenterally. However, with PPN, it's usually just used as a nutrition replacement or a supplement, and sometimes that client is still consuming some oral nutrition. They just can't get enough. So we can discontinue our TPN and our PPN when our enteral or oral intake is at least 60% of our estimated caloric requirements. Okay, so what's in parenteral nutrition? Lots of things. And this, of course, remember, is not something that we are going to decide as nurses. This is something that is going to be prescribed by your healthcare provider and then custom made for your patient by your pharmacy. So our carbohydrates are our first component, that's dextrose. So remember, in peripheral parenteral nutrition, so PPN, up to 10%. Now with TPN, we can be anywhere from that 10% all the way up to 70%. We're also going to have electrolytes, vitamins, and trace elements, and these are going to be based on your serum lab values. So if your potassium level is low, maybe they will add potassium. If your sodium level is low, same thing. So we can add anything that the client needs based on those laboratory values. Protein, those are our amino acids. This can be a concentration anywhere between 3 and 20%, and this is going to be based on 3 things: the client's estimated requirements, and we can estimate protein requirements for client, but then also liver and kidney function. We are going to talk in a few minutes about the laboratory values that need to be evaluated before parenteral nutrition is started, and liver and kidney function are important values that need to be evaluated. Lipids, those are going to be our fats. So they can be a 10%, a 20%, or a 30% concentration. Now, really key point, contraindicated. Your client cannot have lipids in their parenteral nutrition if they have severe hyperlipidemia, hepatic disease, allergies to soybeans, eggs, or safflower oil. Absolutely contraindicated. Now, fats does provide calories if your dextrose must be reduced. So oftentimes a client cannot handle that total parenteral nutrition, so that hypertonic 10% or greater dextrose solution. And so we can add fats into that parenteral nutrition solution and give the client calories Remember, there are 9 calories per gram of fat, a good amount of calories, but we can still keep the dextrose at that reduced level. Now we can add other things as well. Insulin can be added. That will reduce the risk for hyperglycemia, especially if you're using a high dextrose solution. We can add heparin. This prevents fibrin buildup on the catheter tip, particularly of your central line. We can add things like glutamine and antioxidants and pre and probiotics, all based on whatever your client needs. Okay, so what is the evidence of therapeutic benefit? So how do we know that this parenteral nutrition is working for our client? So we're going to look at a couple of different things. The first is going to be our improved nutritional status. And in particular, we monitor the benefit of parenteral nutrition with a prealbumin level. Now we want our prealbumin level to be somewhere between 15 and 36 milligrams per deciliter. That lets us know that we are getting that therapeutic benefit. We also want to monitor for weight maintenance, or a lot of times weight gain is what these clients need. And so what we want to see is either that we're maintaining our baseline or the client is gaining, but no more than 1 kilogram per day. We can also look at our BUN. Our BUN being between 10 and 20 milligrams per deciliter does tell us that our client is in a positive nitrogen balance, and that's what we need for healing. So we often do want that positive nitrogen balance when our client is on parenteral nutrition. Okay, let's talk about you as the nurse. So before we administer parenteral nutrition, we want to assess our client's weight, we want to calculate their BMI, and we want to assess their nutritional status. Now, if you're not sure what we mean when we say assess nutritional status, I am going to talk about some labs, but I do have a whole nother video on my channel about assessing a client's nutritional status. Now, when we talk about baseline labs, a CBC, particularly looking at platelets and hemoglobin and hematocrit and red blood cells, those are really important things that we want to know before we start this solution. We also might evaluate a prothrombin time or a APTT, just to look at our bleeding time, especially if we're going to add heparin into this solution. Iron, our lipid profile. Remember, lipids in your solution are contraindicated if your client does have severe hyperlipidemia. Again, here's those liver function tests. We also want to look at renal function studies, a full electrolyte panel. So we want to look at potassium and sodium and phosphate and magnesium and chloride. We want to look at all of those different electrolytes that we know can make a difference in our patient's health. Our BUN, our prealbumin, and our albumin level. Now, our prealbumin is our best indicator of short-term changes in nutrition status. So we want to know where we're starting so that we can monitor for that therapeutic benefit. There's our creatinine, that's our renal function study, and then glucose. We always have to use an electronic infusion device when we administer parenteral nutrition. And if you're going to give PPN, you're going to need a micron filter attached to your IV tubing. Now, that is not going to be added when administering lipid emulsions. So we can have lipids be inside of our parenteral solution, or we can administer lipids separately. However, you will not use that micron filter if you're going to administer lipids. Remember, we do want to evaluate for allergies, so particularly soybean, safflower, eggs, and that's if our lipids are prescribed. Do not administer our solution if it appears oily. We call that a cracked TPN solution. So the surface will look cracked or just have like it has a floating oil on top of it. That is solution that should not be administered. That should just be returned back to your pharmacy. TPN and PPN do both require double nurse verification. So again, you're looking at the order together. You're in the room verifying that you're in the correct room. It's the correct client and you have the correct solution. That includes also looking at your label to make sure that all the correct components based on what was prescribed are actually in the medication or in the solution. And then we always administer parenteral nutrition at room temperature. So oftentimes our pharmacy will send us a bag that we're not quite ready to use yet, and it will get placed in the refrigerator for storage. However, about an hour before you need to administer it, pull that bag out, just set it on the counter in your med room and let it warm up to room temperature before you administer it. As far as ongoing care, so once your client is on their parenteral nutrition, we're going to continue with daily weights, very strict INO, and of course, frequent vital signs. We also want to monitor for infection at the insertion site. So that's where your central line is inserted or your peripheral line is inserted. Now, remember, if this is a central line, we are still doing all the things that we normally do to care for central lines, such as central line dressing changes. If this is a peripheral line, we're just using our aseptic technique to care for this peripheral line. Electrolyte lab value values continue to be monitored throughout administration of the solution, as well as glucose. This is really important. Your blood and sometimes also your urine glucose will be evaluated because you've got all this dextrose that you're administering in your solution. Therefore, your client is prone to hyperglycemia. Now, if your client is experiencing hyperglycemia, we can treat that with either insulin, again, added to the solution, or sometimes you'll just have a sliding scale insulin prescribed, and you can give your insulin sub-Q, your glucose value is, and you can use your sliding scale to determine how much to administer. We want to very carefully monitor our flow rate. If we give our parenteral nutrition too fast, then we can push our client into hyperglycemia. We can also push them into something called hyperosmolar diuresis, and then of course, fluid volume overload. So detrimental complications if we administer this parenteral nutrition too fast. Great test question. If your TPN is not available from your pharmacy and your current bag runs out, so you're waiting on your next bag to arrive, but your current bag has run out, you need to administer or hang a dextrose 10 to 20% in water, so a D10W or a D20W solution, while you're waiting on your new bag to arrive. So this is for total parenteral nutrition. And remember, that's because you've been giving that high dextrose count in your solution. And so you want to continue with that higher dextrose count while you're waiting on your next bag to arrive. If you don't administer that dextrose solution, your client can have what's called rebound hypoglycemia. That could be severe enough to need treatment. Now, the other things to keep in mind with parenteral nutrition is your bag and your IV tubing. So your whole entire setup gets changed every 24 hours. So even if that bag still has some solution in it, at your 24-hour mark, wherever you started calculating from, when you hit that 24-hour mark, all that bag gets discarded and the tubing that's attached to it. So whenever you're administering these high dextrose solution parenteral nutritions, your risk for infection is very high. And so we want to make sure that we don't get contaminants into our bag that could lead to an infection. So changing your bag and your IV tubing every 24 hours. If you're administering lipids, particularly separately, such as a lipid emulsion that you're going to give separately, that bag and that IV tubing need to be changed every 12 hours. So those are really important values or figures to keep in mind. Okay, so when we're ready to discontinue our parenteral nutrition, we do want to discontinue it slowly. So we're not just going to turn it off and take it down. We're going to slowly start to lower that rate. And that's going to, again, help us to avoid that rebound hypoglycemia. Now, before we can completely discontinue this parenteral nutrition, your client is going to need time for their appetite to return. That can take a week or more. And it can also, your client also needs to be consuming an adequate amount of calories. So before this is completely discontinued, we need to make sure that our client is consuming an adequate amount of calories to sustain their weight and their health. Now, we often will begin, or we will always begin, enteral or oral nutrition during this transition. So we're going to start weaning our client off the TPN again, or the PPN very slowly, but we're going to go ahead and start feeding them either an enteral nutrition or they're going to be consuming oral nutrition. And we always start with clear liquids, and then we advance the diet. So just like you're used to with possibly your surgical patients, where you start out with clear liquids and then you slowly progress that diet, that's the same thing that we're going to do as we are trying to wean a client off parenteral nutrition. Of course, as we are doing this discontinuation, make sure that you're closely monitoring your blood glucose. So now our risk is not for hyperglycemia. Of course, it is for hypoglycemia as we start to withdraw that high dextrose solution. As far as nursing care, always monitoring for signs of infection. Remember, when you're administering these high glucose solutions, your risk is for hyperglycemia. That does increase the client's risk for infection. Always your strict aseptic or sterile technique, depending on whether you're working with a central line or a peripheral line. And then always aseptic technique when you're spiking your bags and when you're changing out your tubings and accessing the site. Monitor your blood glucose levels always, again, using either insulin to manage hyperglycemia or dextrose to manage hypoglycemia. monitoring weight daily, strict INOs every shift, and then we're notifying the healthcare provider of a more than 1 kilogram per day weight gain. So remember, weight gain is one of our measures of therapeutic benefit, but we don't want to see a weight gain more than 1 kilogram per day. So remember, 1 kilogram of body weight does equal about 1,000 milliliters of fluid. So if we're gaining more than 1 kilogram per day, our risk, of course, is for fluid volume overload. Okay, there are definitely some complications of parenteral nutrition. The first one, and quite possibly one of the biggest ones, is infection and sepsis. So we're going to watch for elevated temperatures and an elevated white blood cell count. So that's why we're continuously monitoring those lab values throughout this administration. So oftentimes when someone is on TPN or PPN, we are checking lab values sometimes every day, sometimes every other day, probably no more than every third day. We also need to monitor for metabolic complications. That's our hyper or hypoglycemia. We can also have hyperkalemia, hypophosphatemia, hypocalcemia. Of course, we could also have dehydration, fluid volume deficit, and then also fluid volume overload. So monitoring closely for those symptoms. Mechanical complications. So this is where our catheter maybe becomes displaced. We get an embolus that forms at the tip of our catheter. These are particularly dangerous problems if you're using a central line. You could also develop a thrombosis, or your line could become obstructed or with a thrombosis, or you could accidentally bolus your infusion. This is the reason that we always need to be on an infusion pump. Refeeding syndrome. This occurs when the body rapidly changes from a state of starvation, which is a catabolic state, to an anabolic metabolism where nutrition is being restarted. So you have a client that has been in a catabolic state of starvation, and now we're refeeding or starting to feed the client again. This can result in pretty significant fluid and electrolyte imbalances. So again, that's why we're monitoring those electrolyte imbalances pretty frequently, and we're always alert to our signs and symptoms of fluid volume deficit versus fluid volume overload. Of course, shallow respirations, confusion, seizures, weakness, a lot of that is related to electrolyte imbalances. We can have cardiac dysrhythmias as a result of those electrolyte imbalances. Of course, we can retain fluid and we can end up in a state of metabolic acidosis. Okay, guys, as a special treat today, I do have a couple of practice questions that we're going to look at for parenteral nutrition so that you can check your understanding. So the way I'll go through these is I'll read the question, I'll give you a couple of seconds to think about what your answer is, and then I'll show you the answer. We'll talk about it, and then we'll move on to the next question. Okay, so the first question is going to be, when fat is added to a TPN solution, which statement is most accurate? And this is a select all that apply. So we have 5 answer options. We have concentration of lipid emulsion can be up to 30%. Adding lipid emulsion gives the solution a milky appearance. Check for allergies to soybean and eggs. Lipid emulsion prevents essential fatty acid deficiency. And lipids provide calories by increasing the osmolarity of the parenteral nutrition solution. So I'll give you a couple of seconds and then we'll talk about the answer. Okay, so let's look at the answers to this question. The first answer is going to be the concentration of lipid emulsion can be up to 30%. That's a correct answer. Remember, you can have a 10% lipid emulsion, you can have a 20% lipid emulsion, or you can have a 30% lipid emulsion. The next answer option is going to be adding lipid emulsion gives the solution a milky appearance. That's true. So when you add lipids in, your TPN is going to look milky, or of course, if you're giving your lipids separately, it looks very, very milky. It's a white solution. We are, of course, going to check for allergies to soybean and eggs. If we're adding fat, that is an absolute contraindication to giving lipids. And then our another answer is going to be lipid emulsion prevents essential fatty acid deficiency. Okay, so 4 answers to this question. Let's talk about E. E is not a correct answer because remember, the reason that we often add lipids is to provide those calories while decreasing the osmolarity of the parenteral solution. So remember, osmolarity is concentration. And sometimes we want to keep that client in an isotonic solution, or at least a decreased osmolarity solution. We can do that by decreasing the dextrose, but increasing the lipids and still get the calories. Okay, next question. A nurse is planning care for a client who has a new prescription for PPN. Which action should the nurse include in the plan of care? And this is also a select all that apply. So first answer, document baseline client weight, then review serum prealbumin levels, plan to administer an IV solution with 20% dextrose, add a micron filter to the IV tubing, and finally use an IV infusion pump. And I'll give you a few seconds to think about it. Of course, you can always pause the video if you need more time. Okay, so let's review this question. So our first answer is going to be document baseline client weight, right? We need to know where our client's weight is starting so that then on a daily basis, we can monitor, are they losing weight or are they gaining weight? We're going to review serum prealbumin levels. Remember, prealbumin is your best indicator of short-term changes in nutrition, such as when we are administering a parenteral solution. So we need to know where we start so that when we monitor that prealbumin level every other day, every third day, that we then know if we are achieving therapeutic benefit. Our next answer is going to be to add a micron filter to the IV tubing. And then remember with PPN, we do need to add that micron filter. And then our final answer, use an IV infusion pump. Always, always, always. So let's talk about C, plan to administer an IV solution with 20% dextrose. That is not a correct answer because with PPN, our max dose can be 10%. So no more than 10% in a peripheral parenteral nutrition. If you need to administer higher than 10%, then that's considered total parenteral nutrition, and we will need a central line. Okay, next question. A nurse is preparing to administer a TPN solution and notes a cracked appearance. Which action should the nurse take? This is not a select all that apply, and our answer options are shake the bag to mix the lipid, turn the bag upside down one time, return the bag to the pharmacy, or administer the bag of solution. And so hopefully this was an easy one. Of course, the answer is return the bag to the pharmacy. A cracked appearance means that your TPN is not, you're not able to administer that to the client. It needs to be returned and you need a new bag. So that's that. Cracked appearance is that oily, floating, fat looking appearance on the top of your solution. A nurse is caring for a client who is receiving TPN through a central line access device, but the next bag of solution is not available for administration at this time. Which is an appropriate action by the nurse? So we have four answer options. Administer 20% dextrose in water IV until the next bag is available. Slow the infusion rate of the current bag until the solution is available. Administer normal saline and monitor for hyperglycemia. And finally, monitor for hyperosmolar diuresis when the infusion runs out. Okay, of course, our answer to this one is going to be A, administer 20% dextrose in water IV until the next bag is available. So this client has been receiving a total parenteral nutrition that is a dextrose count over 10%. And so when that solution runs out, in order to prevent hypoglycemia, and to continue to provide those calories, we do want to administer a 10 to 20% dextrose in water solution. We would not slow the solution. We need to administer that solution at the prescribed rate. If we slow the solution, we can again cause hypoglycemia. We do not want to administer normal saline. Of course, if we administered normal saline, we would monitor for hyperglycemia. We would monitor for hypoglycemia. And then we don't want to monitor for hyperosmolar diuresis when the infusion runs out. because that's hyperglycemia. If the infusion runs out, our risk is for hypoglycemia. Okay, and the last question, which statement is correct about medication compatibility with TPN? So we have 4 answer options. Use the port on the TPN IV tubing to administer antibiotic. Regular insulin can be added to the TPN solution. Administer heparin through the same port as the TPN solution, or administer vitamin K IV bolus via a port on the TPN tubing. Okay, so remember, no medication in an IV port that is running TPN or in the tubing in which TPN is being administered. So the only correct answer to this question is regular insulin can be added to the TPN port. Now we can add heparin into the solution. We can add vitamin K into the solution, but we cannot administer it in the same port as the TPN solution or into a port on the TPN tubing. We can also not administer antibiotic through a TPN line. Hopefully you enjoyed this format of trying a few sample questions at the end of the video. So if you liked that format, please do leave me a message down in the comments so that I'll be sure to include questions the next time if I know that that's something that you like. Have a wonderful day, and I will see you in the next video.